Welcome to AZIN's Journal Club, episode 53. I am Dr. Z, and today Casey and I are covering a trial that tackles one of the most challenging and dangerous clinical scenarios in the intensive care unit, hyperactive delirium in a patient who is not intubated. The 4D trial was published in Intensive Care Medicine in December 2025. Casey, give us the one-sentence summary.
The 4D trial was a randomized controlled trial that tested whether dexmedetomidine reduces delirium duration in non-intubated intensive care unit patients with hyperactive delirium and found that it does, with a statistically significant reduction compared to placebo.
Let us set up the clinical problem first. Delirium occurs in 30 to 50% of critically ill patients. Hyperactive delirium specifically involves agitation, restlessness, and combative behavior. In a patient who is not intubated, that creates a real management dilemma. You need to control the agitation to prevent self-harm and device removal. But most sedatives, particularly benzodiazepines and propofol, carry serious respiratory depression risk in non-intubated patients. One wrong dose can mean intubation. KC, what is unique about dexmedetomidine in this context?
Dexmedetomidine is an alpha-2 adrenergic receptor agonist. It provides sedation and anxiolysis by mimicking natural sleep patterns through actions on the locus coeruleus. Crucially, it has minimal effect on respiratory drive at standard doses, unlike benzodiazepines or propofol. That makes it potentially safer in non-intubated patients. It does cause bradycardia and hypotension as class effects, so hemodynamic monitoring is required.
Now walk us through the 4D trial design.
The trial was conducted at 9 centers in France between December 2017 and February 2022, so it took several years to recruit. Eligible patients were non-intubated intensive care unit patients who tested positive for delirium using the confusion assessment method for the intensive care unit and had a Richmond agitation and sedation scale score of +1 or higher, meaning at least mildly agitated. Patients already intubated or on pressure support ventilation through a tracheostomy in the prior 24 hours were excluded. Patients were randomized to dexmedetomidine infusion or placebo.
What was the primary outcome and what did they find?
The primary outcome was delirium duration. The dexmedetomidine group had significantly shorter delirium duration compared to placebo, with a median of approximately 2 days versus 4 days in the placebo group. The adjusted hazard ratio was around 1.5 in favor of dexmedetomidine, and this was statistically significant. Secondary outcomes also favored dexmedetomidine: lower need for rescue haloperidol, fewer days with physical restraints, and, importantly, less escalation to intubation.
That last point is clinically meaningful. Avoiding intubation in a critically ill, delirious patient who is not yet intubated matters enormously. Intubation in that setting carries its own set of risks: ventilator-associated pneumonia, muscle deconditioning, prolonged intensive care unit stay.
The adverse events in the dexmedetomidine arm were primarily hypotension and bradycardia, consistent with what we expect from the drug class. These were manageable and did not lead to significantly more serious safety events. No excess in respiratory failure or unexpected cardiovascular events.
Before we call this practice changing, let us talk about limitations and caveats. Casey?
The trial was relatively small, conducted at 9 French centers, which may limit generalizability to intensive care unit systems with different staffing models, sedation protocols, or patient populations. The control arm used placebo with open-label rescue haloperidol, which is the standard of care in France. In some institutions in the United States, the comparator might look different. And the trial was not powered for mortality or long-term cognitive outcomes, so we cannot say dexmedetomidine improves survival or prevents post-intensive care syndrome.
There's also the issue of blinding. The study drug was blinded, but the overall management strategy was not, which can affect soft outcomes like duration of restraints or clinician decision to intubate.
And dexmedetomidine requires continuous intravenous infusion in a monitored setting. It is not something you can use on a general medicine floor. It needs an intensive care unit or step-down level of monitoring. Its labeled indication by the FDA is for sedation of intubated, mechanically ventilated patients in intensive care unit settings. Use in non-intubated delirious patients is off-label.
As hospitalists, we co-manage a lot of patients who are in the intensive care unit or who are on the edge of requiring intensive care unit admission because of delirium with agitation. The 4D trial strengthens the evidence base for having a conversation with your critical care colleagues about using dexmedetomidine earlier in the trajectory of hyperactive delirium rather than defaulting to antipsychotics like haloperidol, which have limited efficacy for agitation and carry their own risks. The PODI's guidelines from the Society of Critical Care Medicine also support consideration of dexmedetomidine for agitated delirium management in the intensive care unit.
I want to make sure we mention the non-pharmacologic side of delirium management because the 4D trial and dexmedetomidine exist within a broader context. The ABCDEF bundle from the Society of Critical Care Medicine emphasizes assessment and management of pain, spontaneous awakening and breathing trials, choice of sedation, delirium monitoring and management, early exercise and mobility, and family engagement. Dexmedetomidine is one pharmacologic tool, but it does not substitute for these non-pharmacologic foundations.
Exactly. And as hospitalists co-managing patients, we can reinforce those non-pharmacologic measures on the floor too. Reorientation, restoring sleep-wake cycles, ensuring hearing aids and glasses are in place, minimizing unnecessary overnight interruptions, and encouraging family presence. These matter as much as the drug choice. The pharmacologic data from the 4D trial inform what you reach for when delirium has already escalated to the hyperactive, agitated phase in the intensive care unit. But ideally, we are also working upstream to prevent and identify delirium early. Bottom line, for non-intubated intensive care unit patients with hyperactive delirium, dexmedetomidine reduces delirium duration, reduces rescue haloperidol need, and reduces escalation to intubation with manageable hemodynamic adverse effects in this trial. It is hypothesis-generating and practice-influencing, not yet definitive guideline-level evidence, but meaningful. Thanks, KC. This was a high-yield one for the wards. We'll see everyone in the next episode of AZIN's Journal Club.